Good morning. I'm always excited to give this talk. Well, I'm excited to give all my talks here at Marco, but I'm extra excited to give this talk because it seems like every year there is so much new going on with patients with obstructive sleep apnea. Lots of questions from the audience about management of these patients. So let's dive in. No conflicts of interest to disclose. The objectives for my talk are listed here. And I want to start off with what I think for many people would be the nightmare scenario of a patient with sleep apnea where they die postoperatively. So you might have a 58-year-old male who uses CPAP. He's obese. He's got a BMI of 40. He's got proven sleep apnea. He undergoes some sort of orthopedic procedure or upper airway or abdominal surgery under GA. Has an uncomplicated stay in the PACU. He's sent to an unmonitored bed without CPAP or oxygen. He gets small but within standard of care doses of narcotics for several hours, and he's found dead in bed. ACLS doesn't work if it is attempted at all. And this really is the doomsday scenario that worries everyone when caring for patients with sleep apnea. So let's see if we can think about how we might prevent a scenario like this. We know that sleep apnea has become, certainly the recognition of it, if it's not actually increasing, has become a very significant public health concern. And if you write editorials for the New England Journal or JAMA, you find a way to work a pun into your editorial. So you can see here, these editorialists wrote things like, "It's time for the nation to wake up to the staggering impact of sleep disturbances," or "A Rude Awakening, the Perioperative Sleep Apnea Epidemic." And some people have estimated that sleep apnea may affect as many as 1 billion people worldwide. And one of the points the editorials have made is that we should be paying greater attention to sleep apnea as a perioperative concern in just the same way that we paid a lot of attention to diabetes, asthma, and other chronic health conditions. What is sleep apnea? Let's just sort of set the stage so we're all working from the same standard definition. Sleep apnea is characterized by repeated episodes during sleep of varying duration of complete or incomplete obstruction of the airway. If it's complete, we call it an apnea. If it's incomplete, we call it a hypopnea that occurs during an individual's sleep. These episodes result in sympathetic nervous system activation, hypoxemia, hypercarbia, intrathoracic pressure swings as you try and breathe against a closed airway, cardiovascular dysfunction. And then there's an arousal, the airway patency is restored, pharyngeal dilator muscle tone is restored, the airway is opened. These apneas or hypopneas result from failures of the normal arousal process, and I'll talk a little bit more about that in one slide. And then there are these repetitive things, rinse and repeat over and over many times during the night or whenever a patient is asleep. Now, this is a busy slide, and I'm going to simplify it a little bit. There's no doubt that the inciting event that starts the cascade of sleep apnea is when you breathe in, you create a negative pressure in your airway. That's how air enters the lungs. There has to be a difference in pressure between atmospheric and the inside of your lung. And so there's a negative pressure, and that tends to collapse your airway unless there are forces that oppose that collapse, typically pharyngeal and other muscles in the airway that have tone and keep the airway open. If that tone is lost, your airway will tend to collapse. But that's not the whole story. We now know that's not the whole story. And sleep apnea is viewed as a multifactorial disease with other factors playing a role. So it's not just weak or ineffective upper airway muscles. Your arousal threshold, that is how likely you are to wake up when your airway is closing, may be abnormal. There may be abnormal ventilatory control with your reflexes. And all of these play a role in the development of sleep apnea. And so there is, we call these endotypes. So an endotype is a sort of a disease process that has a very specific pathophysiologic mechanism. So the disease is sleep apnea, but the endotypes may include a low arousal threshold, unstable ventilatory control, as I mentioned, anatomic control, anatomic compromise of your airway. Your airway may be smaller than usual, and your dilator muscles may not work normally. And the reason I'm mentioning this is twofold. Number one, clearly these different pathophysiologic mechanisms may lead to treatments in the future or right on the horizon, as I'll describe towards the end. But I think it also explains the somewhat muddled experience we have trying to look at the literature to determine the risks that sleep apnea pose to health and whether CPAP is an effective treatment or how effective that treatment is. And I'll explain more shortly. This slide just shows an example of 3D reconstructions of images obtained of the airway. On the left, you can see a person that was labeled as someone who has sleep apnea, and I hope you can see compared to the normal, their airway going from the retropharynx to the retroglossal region, retropalatal region, is much narrower and smaller than the other individual. And on the right are 3D reconstructions of the tongue and the fat in the tongue. The fat is in yellow and the tongue is in red. And the individual on the left has sleep apnea, and their tongue is bigger and they have more fat in their tongue compared to the individual who doesn't have sleep apnea. And here's another illustration of this. The images on the left are from an individual before they lost 50 kilograms. And then on the right is that after the weight loss. And I hope you can see their tongue is smaller and the amount of fat in the tongue depicted in yellow is much less. And lastly, along these lines, I've talked about the importance of keeping the pharyngeal muscles that tend to keep the airway open. There is now hypoglossal nerve stimulation that's available. It's an FDA-approved treatment. You may see advertisements on it, maybe late night TV if you're watching. It's called Inspire. It actually works. And the various figures on the slide show that when the stimulator is turned on and the patient is asleep, they do not have flow limitation to their airway, in their airway, indicating that the airway is not obstructed. The amount of apneas and hypopneas go way down, and that effect is sustained. And even on the bottom right, where you can see varying colors of green, that's the amount of snoring that a sleep partner reports for this for individuals with this, and snoring goes way down. And I'll talk a little bit more about this device later on. So putting it all together, an individual may have a small upper airway to begin with, bigger tongue, for example, or small bony space. When the patient is awake, their airway patency is maintained by reflex-driven pharyngeal dilator muscles. When they fall asleep, this reflex muscle activation and output to the muscles are reduced. There's, as I mentioned, other abnormalities in the control of breathing. Airway obstruction develops. Hypoxia and hypercarbia develop as well until there's enough stimulation the patient wakes up, and this cycle repeats many times. Now, if this is your idea of a sleep apnea patient, I want you to change your mental image of what a sleep apnea patient is. Not every patient is like the Pickwick patient. So we know that sleep apnea is common, and it seems to be more common as patients get older. It's certainly as common as asthma, if not more common. It's more common for sure in obese patients than in men. And as I'll show you, at least 10%, if not higher, individuals greater than 65 has sleep apnea. And of course, our surgical population is tending to be older these days. Almost half of commercial truck drivers seem to have sleep apnea. So I like to say when I give this talk, if you're tailgating one of those big rigs on your drive around town or wherever, maybe you want to back off a few extra lanes for that driver that might have sleep apnea. When it's been studied in football players, a number of them seem to have sleep disordered breathing as well. So this table just shows the prevalence of sleep apnea by sex and age, and you can see as the cohort ages, the incidence of sleep apnea increases, such that in the top chart for people in Wisconsin, individuals who were 50 to 59, 16% of women, 31% of men had sleep apnea. Similar results from a cohort in Pennsylvania. So very common, particularly in older patients. We know sleep apnea is associated with a variety of other diseases. Individuals have daytime sleepiness. They have a higher rate of car or work accidents. It increases the risk of hypertension and treatment-resistant hypertension. It has an association with diabetes and type 2 diabetes. Development of atrial fibrillation and other arrhythmias during sleep seems to contribute to the development of coronary disease. And when I talked earlier about how the picture is a little muddled, unfortunately, we know that the treatment of sleep apnea often, but not always, improves health. So you can see in italics, I wrote, although the CPAP is the mainstay treatment for sleep apnea, the efficacy in preventing cardiovascular events has not been consistently demonstrated by randomized trials. And that inconsistency may relate to the fact that it's not just, sleep apnea is not just something that can be treated by CPAP. And so let me give you an example of that. Here are figures. The figure on the left is from an article that was published in the New England Journal a few years ago, where they looked at over 2,700 patients with moderate to severe sleep apnea undergoing with sleep apnea, and they put them into two groups, those groups that received CPAP and those groups that didn't. And the primary endpoint was major adverse cardiac events, if I can say it that way. And there was no difference between the groups. So this was a very disappointing study because we thought that the treatment of sleep apnea surely would decrease these cardiovascular events, and it didn't. And this chart on the right just shows a more recent study showing the lack of effective CPAP on the percentage of time in AFib in patients with paroxysmal AFib, again, showing no impact on CPAP. In terms of the diagnosis of sleep apnea, we can't pick it up clinically. We can guess it. We know it's common. Women may show fewer signs and symptoms. Certainly suggestive features when you see a patient would be a report that they have daytime somnolence, that they snore a lot, that their BMI is elevated, that their neck circumference is larger. But we should always think about sleep apnea and what we think otherwise is healthy patients. A sleep study is usually required to diagnose this. These days there are home sleep studies that can be performed. And I put a reference here that's called The Interpretation of Sleep Studies for Patients with Sleep-Distorted Breathing. It was a nice review article in the Canadian Journal of Anesthesia. You're probably familiar with, but if not, there's the Stop-Bang questionnaire that is widely used. Stop-Bang has 8 different categories: snoring, daytime fatigue, whether the patient has observed apneas, hypertension, and the bang portion is a BMI greater than 35, age greater than 50, a neck circumference greater than 40, and male gender. And you get 1 point if you have one of these features. And you might think, oh, the Stop-Bang is a gimmick. No, it's actually a pretty good screening tool. So in this one study, over 90% of patients with a Stop-Bang score of 6 or greater had moderate or severe sleep apnea. And that if you have a score of 2 or less, it's unlikely that you have significant sleep apnea. And so again, from a recent study, the pre-op Stop-Bang is a valid screening tool to detect sleep apnea in patients undergoing surgery with a high sensitivity and a high discriminative power to reasonably exclude severe sleep apnea. So reasonable tool to use. So then the next question is, okay, we talked about sleep apnea contributes to health problems for patients who are undergoing surgery. What about patients who are undergoing surgery? Is sleep apnea a risk factor? And I think the general consensus is that sleep apnea is a risk factor, certainly for respiratory events, for airway obstructions, possibly things that might require admission to an ICU for better monitoring, hypoxemia. But a recent systematic review said that CPAP after surgery improves oxygenation and reduces the need for reintubation and mechanical ventilation. It reduces apnea frequency and related desaturations, but whether or not it improves other outcomes related to sleep apnea is unclear. And again, I think that relates to the fact that sleep apnea is not just something that can necessarily be treated with CPAP. So there are studies out there that show that individuals who are undergoing cardiac surgery, for example, who have sleep apnea, who will have worse outcomes. And in this study shown here from a couple of years ago, major adverse cerebral cardiovascular events and new post-op AFib were much more common in sleep apnea patients than in non-sleep apnea patients, again, in individuals having cardiac surgery. And in another similar study, severe sleep apnea was associated with an increased risk of post-op cardiovascular complications in this particular study. So again, we think that sleep apnea is a risk factor. But when we apply CPAP to these patients, it doesn't always work. So in this particular study, postoperative CPAP did not improve outcomes. The authors concluded there may be potential benefits in the perioperative use of CPAP, and these studies don't provide any evidence not to use it. But again, I think these studies of CPAP postoperatively tend to illustrate the multifactorial nature of sleep apnea. Not all of those factors can be treated with CPAP. There was a recent review article looking at the impact of positive airway pressure treatment. And again, there's no question that positive airway pressure CPAP will decrease respiratory complications, particularly those related to airway obstruction. They will improve oxygenation, decrease apneas and hypopneas as well. When we think about CPAP or positive airway pressure, and this also applies when we talk to the patient preoperatively, it's important to ask patients if you suspect sleep apnea, or if they tell you they have sleep apnea, and they might even tell you they have a CPAP machine. But the question is whether they use it. So you can't just ask, do you have a CPAP machine? Because they'll probably shake their head. And then if you ask them if they use it, maybe, maybe not, because the CPAP isn't always well tolerated by individuals. Again, we know that CPAP acts as a pneumatic splint to counteract the collapsing forces of the airway when you breathe in, when you inhale. The other thing is that there's been a recent recall of Philips CPAP machines nationwide, and that's probably impacting the ability of patients to actually get CPAP if it's been prescribed for them. What about opioids and sleep apnea patients? And that nightmare scenario I started off the conversation with does relate to the fact that that patient was getting small doses of opioids. And we know that sleep apnea patients may be more sensitive to opioids. And so we need to be very careful in the administration of opioids to sleep apnea patients. And I've been asked in the past, well, what about neuraxial opioids? Can they be used in sleep apnea patients? And there's really only one or two articles that I could find suggesting that their use may be safe, but I'm going to be cautious and say may be safe because there's just not a lot of data about that. But we do want to be careful in the administration of opioids to individuals with sleep apnea. What are some of the recommendations that the societies have put forward regarding the management, the perioperative management of patients with sleep apnea? Well, the Society of Anesthesia and Sleep Medicine has produced a number of guidelines, many of which I've listed on this slide, and I wanted to highlight a few of them. One of the things they wrote is that there's insufficient evidence to support canceling or delaying surgery for a formal sleep study, for formally diagnosing sleep apnea. And I think this is important because there's been some controversy. You see a patient these days, maybe you're seeing the patient for the first time maybe a day before surgery or just the day of surgery, and they have features, maybe their stop bang, for example, suggests that they have sleep apnea. And then the question is, do you proceed? What do you do? And this society is saying there's just not enough evidence to say that their case should be canceled or delayed. Another management issue is, what about the use of CPAP in this setting? And they write that CPAP in previously undiagnosed but suspected sleep apnea patients should be considered case by case, but there's not enough evidence to say that it should be used routinely. So again, this is important. I think we can individualize our care. We don't have to blindly prescribe CPAP for every patient that we think has sleep apnea. And the other thing they wrote, which may be somewhat in opposition to some of their other recommendations, is that patients who are diagnosed with sleep apnea on the day of surgery have an increased postoperative rate of respiratory interventions and an increased 30-day mortality compared to patients who have been previously diagnosed with sleep apnea and presumably treated for their sleep apnea. It's unclear why. So even though they've written that there's no reason to delay the cases, they're also writing that there should be a higher level of concern for these patients who are diagnosed on the day of surgery. There are other recommendations from the Society of Anesthesia and Sleep Medicine, as well as from the American Society of Anesthesiologists. One of them I highlighted was we should be careful in the selection of the agents we use for analgesia, sedation, and the induction of general anesthesia if general anesthesia is used, because of the possibility of postoperative respiratory depression. We should be vigilant for the possibility of adverse respiratory events during sedation using either propofol or benzodiazepines, and that there is an increased risk for opioid-induced respiratory depression, as I mentioned. They also suggest that general anesthesia with a secure airway is preferable to deep sedation with an unsecured and unprotected airway. Additional guidelines for post-op management really have to do with how do we know when a patient's ready to leave the monitored setting of the post-anesthesia care unit. And so they write the discharge from the PACU to a home or unmonitored bed when there's no risk of postoperative respiratory depression. And I find that recommendation a little bit challenging because of no risk. No one can say that these patients have no risk. They should have written low risk, and that their baseline saturation is normal on room air. The American Society of Anesthesiologists has further written that these patients may require a longer stay in the PACU compared to non-OSA patients because of the potential for airway obstruction. And they advise that we should observe these patients where they're not stimulated, where we're not, waking them up to maintain their airway. And the main thing is, can these patients maintain a patent airway, and can they maintain a normal saturation without prompting or other interventions? But there's no time limit attached to these. So if you're going to ask me, well, how long should they stay in the PACU? The answer is until they can seem to breathe normally without assistance and maintain a patent airway. What about where should surgery occur? And I think here, what I'm going to say is probably going to be a little bit in opposition in terms of what's happening in the real world. But I think a patient with sleep apnea can have outpatient surgery if the kind of surgery they're having lends itself to either a very short or relatively short general anesthetic, or maybe it can be done under regional anesthesia. If the kind of procedure is not going to entail so much pain that they require a lot of opioids or any of opioids, if the patient, as they emerge from anesthesia, can protect their airway and maintain their airway. And I put in italics, consideration of ambulatory surgery only if postoperative pain can be predominantly managed with non-opioid analgesia, or in settings where post-op positive airway pressure is feasible. On the contrary, caution is warranted in sleep apnea patients with coexistent, non-optimized comorbid conditions who should not be considered for outpatient surgery. And this is where I think my guess is, speaking to many people during this conference and otherwise, there are patients with sleep apnea having bigger procedures, probably patients undergoing procedures that require more analgesia that are still being done in ambulatory settings. And I think one of the reasons for that is the practical aspects of the way our healthcare is structured these days, the way health insurance companies are driving patients to ambulatory settings, and also because simply there aren't enough monitored beds available in this country or any in the world to take care of all the patients with sleep apnea that are having procedures. I think for other sorts of patients, if they're having more complex procedures, patients that are going to entail greater amounts of postoperative pain where opioid therapy may be unavoidable, where the patient may not be able to support the airway by themselves, where a patient's going to require postoperative CPAP. These are all situations that suggest the patient should be in a hospital, hopefully in a monitored setting. And again, how long to monitor these patients? As I put at the bottom of the slide, despite the significance of post-op respiratory and sedation monitoring of patients with sleep apnea, the current literature is insufficient to guide the timing of discharge to unmonitored settings. Now, I talked earlier about this hypoglossal nerve stimulator. Again, it's manufactured or sold by the Inspire Medical Systems. They claim more than 50,000 of these devices have been implanted. I could find one case report about, the perioperative management of patients with a hypoglossal nerve stimulator. And so the use of this stimulator for airway maintenance outside of its sleep apnea indications is off-label. But certainly, hopefully during a preoperative interview, the patient would mention that they have one of these devices. If you're suspicious or know the patient has sleep apnea, it certainly would be reasonable to ask whether they have a hypoglossal nerve stimulator. If they do, they should bring their remote control device that turns the system on and off with them to the hospital. If they're going to have sedation, I think it would be reasonable to turn the device on. Certainly if they're going to have deep sedation. If they're going to have a general anesthetic, particularly with a neuromuscular blocker, to make sure the device is not activated, it's not going to work. But that's what's out there in the literature in terms of this particular nerve stimulation. An interesting study was published relatively recently, asking the question, are there alternatives to CPAP management for patients with sleep apnea? What about putting the head of the bed up and providing oxygen therapy? And so in this particular study, they used high-flow nasal cannula, oxygen, and 30-degree head of the bed up, and found that it actually was helpful post-operatively in patients with CPAP. The use of oxygen in patients like this may avoid significant desaturations. It also may prolong the apnea period. But these two simple interventions should be kept in mind. Not every patient needs to get CPAP. Sit them up, give them high-flow oxygen. What about in the future? I think there are treatment modalities on the horizon, in fact, maybe on the near horizon. I'm not here to tell you that any of these are actually FDA approved. I'm not here to offer them as alternatives, but I am saying that my crystal ball says in the next couple of years, we'll be seeing pharmacologic treatment for patients with sleep apnea. And there's a couple of things out there. There are drugs that change dopamine and norepinephrine reuptake, and that increase the activity of the genioglossus and will help to maintain airway patency. There is a drug that is a potassium channel antagonist that can be applied topically to the tongue that seems to help maintain pharyngeal airway patency. Again, these are in various phase 2-3 type trials that are out there. You may have read recently, but the GLP-1 agonist Zepbound, tirzepatide, also known as Mounjaro, was recently approved by the FDA to treat sleep apnea. So you may be seeing patients that are coming to the operating room on this drug who have sleep apnea, who've had this prescribed for this condition. You know, the paper in the New England Journal said that it can improve the condition by reducing body weight. I'm not convinced that's the total way this works. These GLP agonists seem to have a lot of different effects, clearly one of which is weight loss, but there may be other effects. But in any event, you're probably going to start to see patients coming to the operating room who have a history of sleep apnea and are now on Zepbound. The other drug that I think is closer in my crystal ball to being used more commonly is carbonic anhydrase inhibition. In some studies, it's had a very powerful effect of reducing apnea and hypopnea effects. As I wrote here, one of the strongest reductions reported in a drug trial in sleep apnea. And there are meta-analyses that suggest short-term use of acetazolamide improves sleep apnea. So again, it's not ready for prime time, but I think within a couple of years, it is possible we will have this as another agent in our armamentarium to treat patients with sleep apnea. So looking back on that patient we started with, what could we have done differently for this fellow who unfortunately died after perhaps an orthopedic surgery? Certainly, we should have been very judicious in the use of sedatives, made sure that any neuromuscular block the patient received was fully antagonized. Maybe the patient should have had a longer PACI stay to make sure the patient could maintain their airway. Maybe they should have gone to a monitored bed. As I talked about in my talks yesterday, I think we are starting to expand our thinking about the use of physiologic monitoring in non-ICU, non-OR settings. And perhaps paid more attention to the use of opioids and use non-opioid analgesics. With that, I'm going to stop. I thank you for your attention. Happy to answer questions at the breaks.